Welcome back to the Deep Dive. Today, we're looking at something pretty counterintuitive, maybe even a bit scary. You're doing everything right, taking your blood pressure meds like clockwork. But could that actually be setting you up for a different kind of danger?
That's exactly what we're diving into, this idea of false low blood pressure. It's a hidden risk, especially for older adults on multiple medications.
The very thing meant to protect you.
Exactly. Our mission today is to really unpack the evidence. These sources show how medication, if not monitored carefully, can lead to falls, serious injuries, even collapse.
And the stats are stark, aren't they?
Yeah.
We found that 12% of seniors on these meds experience serious side effects.
Which is already concerning, but here's the kicker.
Yeah.
Nearly half of those cases, 49%, are likely preventable, just with better awareness and monitoring.
Wow, almost half. Preventable.
And the risk isn't linear. It ramps up fast. Seniors taking, say, 4 different blood pressure drugs, they're facing 5 times the likelihood of medication harm compared to someone on just 1.
5 times. Okay, that's significant. It's not just adding risk, it's multiplying it.
Precisely, it compounds.
All right, let's define this thing. What does this invisible enemy, this false low blood pressure, actually look like? Let's start with a story, maybe. Like Margaret, 72. Her doctor probably thought she was doing great. Sitting BP, textbook, 150/80.
Perfect numbers, right? But then one morning she bends down just to feed her cat.
Simple movement.
And next thing she knows, she's waking up in the ER, severe concussion.
Just from bending over, what happened?
Her blood pressure plummeted, crashed down to 85/50. That's the trap of false low blood pressure. The medication worked maybe a little too well.
So sitting number looks fine, but the body can't adjust.
Exactly. The pills blunt the body's natural ability to compensate for changes in posture or exertion.
Yeah.
You stand up, you bend over, and boom, the pressure tanks because the system can't respond quickly enough.
And the tricky part is, Margaret probably had warning signs, right?
Yeah.
But maybe dismissed them.
Very likely. Things often brushed off as just, getting older.
What kind of signs are we talking about? What should people look out for?
Well, dizziness is a big one. Lightheadedness, especially when you stand up quickly. That affects up to 18% of older adults on these meds. It's a sign the brain isn't getting enough blood momentarily.
Okay, dizziness when standing. What else?
Unexplained fatigue, just feeling wiped out for no reason, weakness, and then the really dangerous one, falls, or even near falls.
Falls seem critical here. Our sources said they account for 13% of all the harm related to these medications.
That's right, 13%. It's often the most dramatic consequence of these silent blood pressure drops.
Okay, any other signs?
Yeah, sometimes you see peripheral edema that's swelling, usually in the ankles or feet. Accounts for about 14% of issues. Or more acute signs like cold, clammy skin, maybe sudden confusion.
Confusion. Why confusion?
It signals that vital organs, including the brain, might not be getting adequate blood supply. And like we said at the start, the risk jumps dramatically with more pills. Remember the PRIME study?
The 4 pills, 5 times risk.
Yeah. Exactly. It's very dose dependent.
So the message is, if you or someone you know is on blood pressure medication, pay attention to these subtle feelings. Don't just assume it's age.
Absolutely. Those perfect sitting numbers don't mean much if you collapse reaching for something on a high shelf.
Okay, let's get specific about the drugs themselves. We're talking about the common ones, right? ACE inhibitors, ARBs, the proles and sartans, beta blockers, calcium channel blockers.
Those are the main players, yes. And the data shows some carry a higher risk burden than others in older adults.
Which ones stand out?
Well, looking at the numbers, the ACE inhibitors and ARBs, the proles and sartans, they actually account for the largest chunk of medication-related harm, around 33%.
A third of the problems from that family. Wow, what's next?
Calcium channel blockers are close behind at 28%, and then beta blockers at 22%.
So those 3 classes alone make up a huge majority of the risk. But I guess the real danger zone is mixing them.
That's where it really escalates, yes. The research pinpoints a particularly risky combination.
Which one?
Taking a calcium channel blocker plus an ACE inhibitor or an ARB and a beta blocker altogether. That specific triple therapy.
The trifecta.
Yeah, right. Patients on that combination showed 3.33 times higher odds of serious harm compared to others.
3.33 times?
Yeah.
So if you're on that specific combo, that's a major flag.
It should definitely prompt a conversation with your doctor, a serious review.
This brings us back to Margaret and that flaw in how we usually check blood pressure. You sit, get the reading, 12, 20, 80, looks great, but that doesn't capture the whole picture.
Not at all. This is where the concept of orthostatic hypotension becomes absolutely critical.
Orthostatic hypotension,
Meaning the blood pressure drops significantly when you change position, usually when standing up from sitting or lying down, or sometimes just bending or exerting yourself.
like the body's internal plumbing can't keep up.
That's a good way to put it. When you stand up, gravity pulls blood down. Your body normally compensates instantly, tightening vessels, maybe speeding up the heart a bit to keep blood flowing to the brain.
But the meds interfere with that.
Exactly. If the medication is suppressing that response too much, the pressure drops, sometimes dramatically, and that's orthostatic hypertension.
How common is that?
It affects roughly 10% of people on hypertension medication. And it's the direct mechanism behind many of those falls we talked about.
So you can have perfect numbers sitting in the doctor's office.
And still be at serious risk every single time you get out of bed or stand up from a chair. The standard check just doesn't catch it reliably.
Which means if you're having symptoms like dizziness, the answer isn't always more medication. It might actually be less.
Precisely. Which leads us to the whole challenge of adjusting these medications.
Okay, let's talk about Robert. 68 years old. His numbers were pretty good, maybe 1, 2, 5, 7, 8. But he mentioned feeling dizzy sometimes.
Common scenario.
So his doctor, likely thinking more protection is better, adds a fourth medication. He ends up in the emergency room. BP crashed to 8852. Terrifying.
Yeah, that happens.
So why is the default often to add more, rather than consider reducing, especially when the baseline numbers look okay or even good?
It's partly ingrained medical thinking, that hypertension is progressive, meds are for life. But that dogma is being challenged.
How so?
There's solid research, including a key study in JAMA, showing that for many older patients already on medication, carefully reducing the antihypertensives is possible. And often, it can be done without losing significant blood pressure control.
That's huge, the idea that you might be able to safely reduce the load.
It is, but it has to be done carefully, methodically. You can't just stop pills abruptly.
Right, that sounds dangerous. So what are the rules for doing it safely? De-escalating.
First rule, always under professional supervision. Stopping suddenly can cause rebound hypertension, which is very risky.
Okay, doctor involved. Then what?
Then we apply similar logic to increasing meds. Remember the 4-week rule? Just like it takes time for a new dose to show its full effect.
You need to wait after reducing too.
Exactly. Give the body at least 4 weeks to adjust and stabilize after reducing a dose or stopping one med before making another change.
Makes sense. And how do you figure out which med might be the problem if you're on several?
That's the one-at-a-time principle. You only change one medication at a time. Reduce or stop just one, then wait and monitor. That way, if symptoms improve or BP changes, you know which drug was responsible.
Got it. One change, then wait. Is there a preferred order for which drugs to reduce first?
Generally, yes, based on ease of reduction and withdrawal potential. The typical reduction order, starting with the safest or easiest first, is often thiazide diuretics first, then calcium channel blockers, then the ACE inhibitors, or ARBs, and lastly, the beta blockers.
Why beta blockers last?
They require the most careful, gradual tapering because stopping them suddenly can cause significant withdrawal symptoms, like rapid heart rate or anxiety.
Okay, so there's a strategy. But even before things get bad enough to need reduction, are there subtler signs the body is maybe over-medicated, like early warnings?
Yes, definitely. Our sources talk about looking for shifts in your energy pattern, subtle clues that often precede the more dramatic symptoms.
Energy patterns, like what?
Think about persistent morning sluggishness, feeling groggy even after coffee, which might mean your heart rate is being suppressed too much overnight.
Okay, morning fog.
Or noticeable afternoon crashes, like feeling suddenly faint or lightheaded between maybe 2 and 4 p.m. That could indicate a drug you took earlier is peaking too strongly.
Anything else?
Sleep disruption patterns, maybe, or issues with temperature regulation, feeling unusually cold, especially in your hands and feet. That can suggest circulation isn't optimal, potentially due to over-medication slowing things down too much.
These are subtle things, but important. They could be the difference between a simple medication tweak and
an ER visit. Exactly. Paying attention to these patterns is key.
But what if we miss those subtle signs? Or things escalate quickly? What are the absolute call for help now red flags? Thinking about Eleanor, 74, stable on 3 meds. A 4th one gets added. 3 days later, she collapses. BP 7845. Just terrifying.
Eleanor's story really underscores the need to recognize the absolute alarms. The most critical is what we can call the stand-up test emergency.
Okay, what's that?
If you stand up, feel significantly dizzy or faint, and if you can check your BP, it shows a drop of more than 20 points systolic, that's the top number, or 10 points diastolic, the bottom number.
Big drop.
Yes, a big drop accompanied by symptoms like dizziness, maybe chest pain, or changes in vision. That's an immediate medical attention situation, possibly 911.
Okay. Stand-up test failure with symptoms. What else is an emergency?
Look for the symptom cluster. That's experiencing several things at once. Significant dizziness, plus nausea, plus breaking out in a cold sweat, plus a rapid heartbeat. That combination suggests a systemic issue, possibly shock. Call 911.
Dizziness, nausea, sweats, rapid heart. Got it. Any others?
Yes, and this one is sometimes missed. The cognitive change warning. Any new onset of confusion, sudden difficulty finding words, or appearing unusually vacant or detached.
That sounds like a stroke symptom.
It can mimic stroke, but in this context, it could signal dangerously low blood flow to the brain due to the blood pressure being too low. It needs immediate evaluation because if it is the BP, it might be quickly reversible.
Okay, so those are immediate emergencies. What about situations that aren't quite collapse, but signal the regimen itself is now high risk and needs urgent review with a doctor?
Right. 3 key scenarios raise red flags. First, the polypharmacy cascade we mentioned. Taking 3 or more BP meds and having any of those symptoms, dizziness, fatigue, falls. Remember, that's 3.33 times the risk.
3 meds plus symptoms.
Okay. Second, the frailty factor. Has there been recent unintentional weight loss, a noticeable decrease in mobility, increased overall weakness?
Why does that matter?
Because frailer individuals often clear medications more slowly, and their bodies are less resilient to BP drops. The original drug trials were mostly on healthier people. The dose might now be too high for a frailer person.
Okay, frailty is warning. What's the third?
Kidney function decline. Doctors track this with blood tests, often looking at creatinine or calculating the EGFR estimated glomerular filtration rate.
Kidney filtering rate.
Exactly. As kidney function naturally declines with age or due to other conditions, the body doesn't eliminate the drugs as efficiently. They hang around longer, effectively acting like a higher dose. If your EGFR drops, the medication doses absolutely need reevaluation.
It connects back to something interesting for the sources, this idea of the 3-day rule. What's that about?
It's a concept borrowed partly from traditional medicine observation, but it's useful. It suggests that if you notice any subtle but persistent change in your energy levels, your sleep quality, your mental clarity, and it lasts for 3 consecutive days.
3 days in a row.
It likely signals a real physiological shift is happening. It's not just a fluke. It warrants paying closer attention and probably mentioning it to your doctor. Don't wait for a big event.
And timing matters too, right?
Yeah.
When is the risk highest?
Critically important. Most medication-related harm, especially from low blood pressure, occurs within the first 8 weeks of starting a new medication or changing the dose of an existing one.
The first 2 months.
That's your peak danger window for developing this false low blood pressure. Be extra vigilant then. #outro.
So the big picture here seems to be that your blood pressure medication plan isn't necessarily set it and forget it. It needs to adapt, especially as you get older.
Absolutely. It has to evolve. The goal shifts away from just hitting a specific number while sitting in a chair towards finding the minimum effective dose.
Minimum dose to get the heart protection.
Without causing dangerous side effects like falls, dizziness, or significantly impacting your quality of life. Those perfect numbers might be hiding a risky reality.
And this isn't just our take, right? The official guidelines are moving this way too.
They are. Even the upcoming 2025 AACC guidelines are expected to emphasize this more. Treatment decisions must be individualized. You have to consider the whole person, their preferences, other health issues, life expectancy, and importantly, their symptoms.
So what works for a healthy 50-year-old might be wrong for an 80-year-old experiencing dizziness.
Exactly. And that supports the idea of sometimes reducing medication, even if the BP numbers look okay on paper, if the patient is suffering side effects. Quality of life and safety are paramount.
Okay, this has been incredibly insightful. So for listeners, what are the concrete actions they can take?
First, take stock. Know exactly what blood pressure medications you're taking, names, doses, when you take them. Are you on 3 or more different classes? That's step 1.
Know your regimen. Got it.
Second, make a specific appointment with your doctor or healthcare provider. Don't just tack it on to another visit. Schedule time to specifically discuss any symptoms like unexplained dizziness, fatigue, falls, near falls. Mention orthostatic hypotension. talk about the risk scenarios we covered today.
Be proactive. Go in armed with this information.
Be an informed partner in your care.
Great advice. Remember, the goal is cardiovascular protection without sacrificing your safety or daily life. Work with your team. And of course, we have to say it.
Always, never make changes to your medication regimen, starting, changing doses without consulting your doctor first.
Abrupt changes can be dangerous. Rebound hypertension is real.
Absolutely. Talk to your doctor. Find that right balance for you.